We propose an arthroscopic technique for combined reconstruction of the anterior cruciate ligament and anterolateral ligament, preserving the pedicled semitendinosus tendon and creating single femoral and tibial tunnels. The patient is positioned supine, with the operated leg hanging down. These various skin markings are made beforehand. Hamstring tendon autografting is performed by means of an oblique incision 6 cm below the joint line and 2 cm medial to the tibial tuberosity. The semitendinosus tendon is left pedicled at its tibial insertion, while the gracilis tendon is severed at its distal insertion. At this stage, the size of the graft obtained is simulated to determine the size of the future femoral and tibial tunnels. The intercondylar notch is debrided, preserving the tibial remnant of the anterior cruciate ligament. A first arthroscopic step is necessary, involving exploration of the various intra-articular components of the knee. The tibial guide, set at an angle of 55-60 degree, is positioned via the incision used for hamstring harvesting. Intra-articularly, it is positioned within the remnant of the ruptured anterior cruciate ligament. A guide pin is then inserted, and the tibial tunnel created by successive meshing until a tunnel corresponding to the size of the previously obtained graft is obtained. The intra-articular part of the femoral guide, set at an angle of 110 degrees, is positioned on the medial side of the lateral femoral condyle, within the anatomical footprint of the former anterior cruciate ligament femoral insertion point. The extra-articular part is positioned posterior and proximal to the lateral epicondyle, corresponding to the proximal insertion of the anterolateral ligament. A tunnel is then created by increasing the mesh size of the previously measured graft. A traction wire is then introduced intra-articularly via the femoral tunnel, then recovered and passed through the tibial tunnel. The fiber stick is now placed intra-articularly to measure the required anterior cruciate ligament graft size. The anterolateral ligament tibial tunnel is created positioned distally approximately 1 cm below the extra-articular entrance to the tibial tunnel, and proximally between 4 and 10 mm below the joint space and equidistant from the center of Gerdy's tubercle and the anterior edge of the fibular head. After increasing mesh size, a second traction wire is passed through this tunnel via the guide wire. The distance between the tibial insertion zone of the semitendinosus and the extra-articular entry orifice of the tibial tunnel is recorded. 10. The graft is prepared so that the anterior cruciate ligament graft consists of 3 strands of semitendinosus and 1 strand of gracilis, and the anterolateral ligament graft of 2 strands of gracilis mounted on an endobutton. The length of the anterior cruciate ligament graft corresponds to that previously measured with the fiberstick. The correctly prepared graft is positioned intra-articularly, with the tractor wire first passed through. The graft is then fixed at the femoral level by a fast thread bicomposite resorbable interference screw tightened, then at the tibial level by a second knee interference screw at 20-30 degree flexion. The anterolateral ligament graft is then inserted using the second tractor wire and secured with the knee in extension and neutral rotation. The endobutton wires and those passed to the proximal part of the graft are finally knotted together. An arthroscopic step is required to check that the anterior cruciate ligament graft is correctly tensioned and positioned, and that there is no conflict between the graft and the roof of the notch when the knee is in extension. Finally, an intra-articular injection of neuropain was administered.